most of these date back to the 70s, early 70s, and you can kind of see what the health trend was based on what the mandate is at the time. But these mandates are critical coverage for consumers, and when the ACA came into play, these all became incorporated as part of our base benchmark product. So slide 1 goes through required mandates on disabled children, home health, skilled nursing care, kidney disease, coverage for newborns. And we have a really good publication at our oci.wi.gov. And if you go to our consumer tab, you can find and then type in search for mandates. We have a really nice publication that's going to walk you through a summary of each of these mandates. And I'd rather you go and practice going on our website and pulling that up when you have time to take your time looking through these mandates and learn them that way, other than my just telling you what each of these are. The words themselves are fairly self-explanatory, but think again, these were in 1970 for the most part. Most of these mandates were in place. Obviously, there's some newer ones, but for the most part, Wisconsin was always on the front edge of consumer protection, and most of those protection actions were taken in the form of mandated benefits for consumers. So again, if you go to oci.wi.gov, under our consumer tab, you will just type in mandated benefits, and you're going to see a nice booklet on all of these. So the next slide is the next grouping of benefits. One of the things that you're going to be interested in is the diabetic supplies and equipment, and that includes insulin pumps. So we're one of the few states that have that as a mandate. And pumps, rather than under Medicare, Medicare follows kind of the DME when 3 years useful life. Wisconsin has one pump that you can get at no more than once a year. So it's a huge benefit. Slide 3, the third of these mandates. So TMJ was a big thing in the early 80s, late 70s, and it came out in a form of a mandate. Immunization is really for children. So when you look through that document, it's for children up to age 6. Autism spectrum disorders is a newer benefit from the mid-2000s, approximately 2007. And this was really a significant change in a mandate, and it was a very detailed statute and a very detailed administrative rule. And it, I think, has made a big difference in a lot of lives of consumers in Wisconsin. The next slide, for hearing aids and cochlear implants for children, not adults. This is for kids. You can get up to 1 per ear, and I think it's no more than every 3 years. There is still some issues with as children grow, the outer edges of their ear change, and so sometimes fit becomes an issue, but for the most part, this has been hugely helpful. The contraceptive mandate is for the prevention of pregnancy. It is different than the federal mandate, and it does not necessarily, is not nearly as broad as the ACA. The next slide are benefits that I call contingent mandates. They're kind of set up as an if-then. So for oral and injected chemo, if an insurer provides coverage for injectable inpatient chemo, then they must also provide access to oral outpatient chemo. If you have coverage for prescription eye drops, then you shall also be able to have that refilled early, with the assumption that most times when someone's putting eye drops in their eyes, they're going to miss their eye. And if those are titrated at, to make it 30 days and you miss a ton of times, you're going to need to get that refilled earlier. That's what that one allows you to do. Chiropractic benefits is often misnomed as kind of a chiropractic mandate equity. But what it really comes down to is that if an insurer is going to cover a certain procedure, and let's say a manipulation, there are lots of different types of providers who can do that, a PT, an OT, a neurologist, and an orthopedist, but so too can a chiropractor. And as long as that's covered, they cannot discriminate against chiropractors doing that same benefit. So they have those rights. And COVID-19 testing on the slide is a new mandate that when there's testing available that has been that is caused by the SARS, they need to cover that testing cost without imposing co-payment co-insurance for that test. Again, if you go in for an office visit for some other reason, and part of that is the test won't have a cost share, but the office visit could. So again, I intentionally did not spend a lot of time on those. Clearly, we have a lot of benefits that are available for consumers and truly help our consumers. So if we go to the next slide on marketing practices, this is going back to your role now as a navigator or a CAC and what we're watching as an office for conduct of how people behave out in our community with our citizenry. So advertisement rules, really, advertisements have to be truthful. They can't be misleading. They can't be disparaging. They can't say, you know, Cigna sucks and make that a part of their ad campaign, or they can't be deceptive. We recently saw some Medicare marketing that said literally the lead in the big bold letters were kind of, you know, find the benefits you haven't been using under your traditional Medicare. Nowhere except for the tag on a tear off piece that actually got mailed back in did it say that an insurance company was going to call you if you turned that card in. The complainant in that matter actually thought he just wasn't getting the benefits that were available, and he didn't know that there were some benefits that were covered under Medicare A and B or under a supplement, and had no idea until the very end, and actually the loss of his insurance, that what he was being sold was a totally different product. It was an Advantage product. So we really watch advertising very carefully. Unfair marketing practices, we just want, again, the whole goal for the insurance office is fairness. So we want a level playing field. We want things to be truthful and straightforward. We don't want people to try to coerce or induce you to buy a product. We don't want you to be discriminatory. We don't want misrepresentations. We don't want to unfairly restrain competition. You can't say, oh, Dean's the best and UW Ports sucks. I mean, you can't just say, I'm not going to show you that plan because there's been too many problems. You can't do that. That's restraining the free right for competition. And remember, the goal underlying all of our insurance is that we want a free marketplace. If it's a free marketplace, you should be able to see everything. We don't want people throwing extra charges and trying to make money off of people. That's not appropriate. We don't want people using their official position. So if you called into OCI, there is no one at this office that is going to say, pick ABC Insurance Company. We will not do that, because by being an OCI employee, there's presumed that we have unique knowledge, and we probably do. But we would never use our position to persuade or dissuade someone from looking at a product. And home solicitations, we do take very seriously, because this is a huge area of opportunity for harm. So think aggressive sales tactics in a home where someone may be physically limited in mobility, or who has medical conditions that need regular breaks or regular food. And if the solicitations are long-winded, or they refuse to leave, or they're very intrusive, this is someone coming into your home. We put up a lot of walls and requirements to protect consumers with that. So all of those things are being heavily regulated and monitored by the office. Again, you on the front line may hear of something. We want to know. Send us a complaint. You know, Susie was in a wheelchair and an agent barged through and walked right to the kitchen and sat down. Tell me about it. We want to know what's going on, because you are the eyes and ears for the office when you are out and about in the state working with our consumers. Next slide is a polling slide. So which are following examples of unfair marketing practices? misrepresentation, unfair inducements, extra charges, or all of the above? And the poll is working on your side of your slide area. We should have like Jeopardy music in the background for you guys.
I agree. So that's exactly 30 seconds, that song is, I believe. But I think we would also have to pay for the rights, so I don't think we can manage that.
Oh, well. All right, let's see what the results are. And it is 92%. Yes, correct. All of those actions are indeed examples of unfair marketing practices that we do not want to see in the state of Wisconsin. Next slide is continuing with the marketing methods. So insurers and agents are responsible for the suitability of the sale. If you remember, yesterday we talked about a lot of these accepted benefits. So that there's a cancer policy and there's a hospital policy and there's an accident policy. And you can basically get a separate policy for every kind of feature of insurance. It's probably not suitable for a person who has underlying coverage that is comprehensive to need every single one of those lines. Now, it also doesn't preclude someone from saying, I am so risk adverse, I want that, and I have so much money that I am comfortable paying all of that. That's okay, but we're going to look to the insurer and to the agent that if a sale of insurance happens, it's appropriate. Agents are appointed by the insurer to represent the insurer in sales and marketing. And this is important because the insurer is going to be responsible for any acts that that agent does, which comes back down to our licensing. We want to be sure that these people are competent and trustworthy. Agents typically are compensated through commissions. So that's, Eric mentioned earlier today that one of the things that we do watch is that there's no incentive to try to build up your commissions. So if you get $10 for selling a marketplace product or as an agent, but you can get $150 if you sell someone 10 other policies that are basically useless, we have a problem with that scheme, right? So we're going to look at that agent's behaviors. And I'm going to turn the mic over to Eric for the next slide.
Thanks, Julie. Okay, so the next slide is short-term limited duration policies, and these are actually plans that we discussed during yesterday's sessions as well. So this is a bit of a reminder or a refresher. But short-term limited duration plans are, again, a type of health insurance coverage that was originally designed to fill temporary gaps in coverage that occur when a person transitions from one plan to another. As a reminder, short-term limited duration plans can, and they typically do, exclude coverage for pre-existing conditions. Short-term limited duration plans, the coverage for those are exempt from the individual market requirements because they are not considered individual health insurance coverage under the Public Health Service Act. People cannot use ACA subsidies toward their short-term plan premiums. And it's also important to know that cancellation or non-renewal of a short-term limited duration policy will not typically trigger a special enrollment period. So therefore, as an example, an insured who has been diagnosed with say, diabetes, while covered by a short-term limited duration plan, may not be able to obtain coverage until open enrollment. And finally, there are no guaranteed renewals of short-term policies. Moving on to the next slide is healthcare sharing ministries, HCSMs. We also discussed these during yesterday's sessions. So healthcare sharing ministries are non-insurance entities in which members share a common set of ethical or religious beliefs and share medical expenses among members in accordance with those beliefs. The ACA's rules regarding healthcare sharing ministries are outlined in the listed section on the slide there under the Affordable Care Act rules. HCSMs are not a discounted insurance program, and they are not traditional health insurance. As a reminder, HCSMs are also not required to cover pre-existing conditions, just like the short-term limited duration plans. They're not required to cap out-of-pocket costs either, and nor are these HCSM plans required to cover essential health benefits. With that, I'll switch it back over to Julie.
So you've heard about health insurance exchanges. You know the ACA was based on the premise that a state could create their own state-based exchange. Most of those have shifted to the federal platform, although recently coming on for either 21 or 22, a state actually has added to become their own state-based exchange. There are state-based exchange. Colorado and Kansas, I believe, still have theirs. And this is the reason it was really difficult for states to actually create these is the amount of IT costs, and we had an incredibly short time to get up. So if you remember, this was passed in March of 2010, and you had to be up running to take enrollees by January of 2014, which is not a lot of time to get all the infrastructure, all the laws, all the regulations, everything in place, including a working big, huge website. States can choose in the future, if they want to become a state exchange or a state partnership plan, which is working with the federal. So they may use the federal platform, but control components, more components of the insurance. Wisconsin is a federal-based exchange, not a state-based exchange, but we do have retained jurisdiction over rates and form filings. A private exchange, if you hear that phrase, is not the same thing as a state-based or partnership exchange or the federal exchange. A private exchange is an exchange set up by an employer for their employees to select health and other benefits, and it's typically self-funded by the employer. The next slide. So you've heard the word qualified health plans. Qualified health plans are certified by the Federal Health Insurance Marketplace. They provide the essential health benefits. They must follow established cost sharing limits. They must meet all the requirements of the ACA. QHPs that offer on the federal exchange must also offer the product off the exchange. That way, if consumers who may not be, one of the big benefits of going on the exchange is if you are in an income level that allows you access to advanced premium tax credits or some cost sharing reduction or some fluidity like for American Indians or Native Alaskans that you cannot get off the exchange. But sometimes the products might be cheaper off the exchange, and the same things have to be available in both places. Next slide. So you've heard in the last 3-4 years about this minimum essential coverage for the ACA. MEC is the cute little acronym for it. It is the requirement for individuals to maintain insurance. So when you're filing your insurance, your tax forms annually, one of the questions and forms that you receive if you have employer coverage or if you have individual coverage, you're going to get a document that shows that you've had insurance that year. The reason you're getting that is to avoid a tax penalty. Currently, the federal tax penalty is 0. The law actually still exists. It was not taken down by the current administration, but it was taken to a $0. Any insurance plan that meets the ACA requirements for having health coverage are available. So insurance bought through the federal marketplace, individual health plans that meet the standard qualified health plan QHP requirements, grandfather plans that include retiree coverage or COBRA, Medicare Parts A or C, so A is inpatient, C is drugs, most Medicare coverage except limited benefit or a duration type coverage, children's health insurance plan, you might have heard of the term CHIP, or VA, or the veterans insurance is called TRICARE. All of those would qualify as being minimum essential coverage under the ACA and would take you out of a tax penalty situation. Next slide. So the essential health benefits that must be included in a qualified health plan are the ones that these top 10 are listed. So ambulatory patient services, that's outpatient, emergency services, hospitalization, maternity and newborn care, mental health and substance use and disorders, including behavioral health, prescription drugs, rehabilitative and habilitative services. So a habilitative service is a benefit that helps maintain what you have learned and maintain functioning. Rehabilitative is where you return to a functioning level. So it's the process of returning. Laboratory services, preventive wellness services, and pediatric oral and vision. Again, this is pediatric. Oral and vision is not an essential health benefit for adults. So the ACA provides that each state established a benchmark plan, and it must include these 10 essential health benefits and serve as the minimum standard for all the products that are sold in Wisconsin. So Wisconsin's is the EHB plan. If you go to our website and search benchmark plan, it's going to bring up both the policy and all the long forms of what we have established is the base product. So it's going to be a product that has our mandates in it. It's going to be a product that is going to comply with each of these areas of the EHBs under the ACA. I'm now going to start talking more slowly and go through what I think is more information that you're going to want to have for doing your job as a SDAC or a navigator. So there is financial assistance within the ACA. The advanced premium tax credits is a federal tax credit to help individuals and families afford health coverage that is purchased through the health exchange. The premium tax credit can be taken in advance, that's the advance word, or not. So an individual can choose if they want to take the premium tax credit monthly, which is what most people do, or you can have that as money that comes back to you when you get your tax refund after filing your federal taxes. What the APTC will do is reduce your premium. So if the premium that you saw when you went into the healthcare.gov and you selected your plan came out $200, but when you put in your financial information, you became eligible for advanced premium tax credit, you may end up only paying $50 in premium because you have sufficient amount of advanced premium tax credits that will lower your premium. So this is again really important why you need to keep your profile on the federal exchange updated, because if you have a loss of income or you have gained income, it may change that APTC dollar amount, and you can change that throughout the year. So if you get a new job or change a job or a promotion or a loss of job, that you want to get updated, because if you do not update it and you end up actually only being eligible for a smaller amount of APTC, but you didn't let the feds know, you're going to owe that money back when it comes to tax time. Tax credits can offset that premium that you pay directly from the federal government to the insurer. So this isn't money that the feds are handing you when you're making your premium payments. They're paying that portion directly to the insurer that you selected. Those claiming the premium tax credits as a refund, instead of using them monthly, will pay full insurance premium then each month, and then subtract the tax credits from taxes owed at the end of the year when they file their federal taxes. Cost sharing reduction is a financial assistance available, again, through the ACA on the marketplace. It is income based. So, and again, it is paid directly to the insurer that the consumer selects, and it significantly alters the amount of co-pays, out-of-pocket deductibles, co-insurance, and co-payments additionally. So we've used these words, and I want to be sure that you're understanding what they are. The deductible is the amount the employee must pay for covered health services before the insurance company will pay. Coinsurance is a percentage of allowed charges an enrollee pays for covered health services after they pay the deductible. So some typical things that have cost coinsurance might be an emergency room visit, or DME, durable medical equipment might have a coinsurance that you have to pay like 20%, and your insurer will pay the 80% after you've met your deductible. Copayment is a fixed amount of money an enrollee pays, like to a doctor. So if you have kids, you might go for a checkup, and it's a $10 fee. Often those may or may not accumulate towards your out-of-pocket maximum, or lovely called MOOP, M-O-O-P, maximum out-of-pocket, which is the amount that no matter what happens, that's the most your individual family is going to have to pay before your insurance company is paying fully. This does not include like some of the free services like the preventive care services. Those can get paid right away. So cost sharing reduction is only available through the insurance exchange marketplace for individuals with incomes below certain levels and who choose a health plan from the silver metal tier level category. Cost sharing reduction doesn't include premiums, but or dealing with balanced billing if you went to a non-network provider, or non-covered services. This is when it's a covered benefit. This is where this benefit comes into play. The ACA is expanded a lot of coverage for lots of people, but in particular, what it did is make permanent the reauthorization of the Indian Healthcare Improvement Act. So this was an act that had to keep getting renewed and often did not get resolved by Congress timely. And this was, the ACA embedded this act within the ACA. So it houses the Indian Health and Care Improvement Act. So when you hear of the ACA going away, so too would this reauthorization for the Indian Healthcare Improvement Act. That's pretty significant. For American Indians and Alaska Natives, the ACA helps address health disparities by investing in prevention and wellness and increasing access and affordable health care. They have some special enrollment opportunities. American Natives and Alaska Natives can actually come on and off enrollment monthly. They do have to enroll through a QHP. They can, as their money changes, they may need to be, some members of their family, if they're not all blood quantum or members of a tribal unit, may need to be in Medicaid and have an ACA plan. So this is a bit complicated. There are a lot of expertise available to help navigate this part of it, but it is an embedded part of the ACA. Next slide. So the rest of the slide deck that I'm going to present to you is really going to walk you through how someone would make a decision on selecting the right insurance for them. So on the marketplace, you start by creating an account at www.healthcare.gov. Once your family is in that and your financial information is in that system, then it helps walk you through the next steps of selection and options. In this process, you might be found to be actually eligible for Medicaid, in which case they're going to link you off the exchange and direct you into a gateway to DHS. And I believe DHS talked to you on Monday about this component of it. Just the same, you can also become ineligible for Medicaid and be able to walk back into the healthcare.gov. You may be able to get cost sharing reduction based on that information. So when you're working with a consumer, as accurate as they can be with their financial information is critical. Silver plans are going to vary by each geographic region within the state, and it's based off of the second lowest cost silver plan for advanced premium tax credits. But on APTC, you're not limited to staying on that plan. you can use that credit on other products. And remember that the marketplace is the only place you can get advanced premium tax credits or cost reduction. So when you're working with a consumer, you're going to want to figure that out pretty early to help navigate them and help them make decisions, because that's going to make things more or less affordable for them. Next slide. So you may be found to be eligible on the marketplace with advanced premium tax credits. This credit can be taken in advance of filing your annual taxes in the form of this monthly premium reduction. The amount of assistance is calculated, as I said, off of the second lowest cost silver plan near where you live, but it also you can apply it as credit against a bronze, silver, gold, or platinum product. So let's say in my earlier example, a premium was $200 for a silver product and you became eligible for $100 of advanced premium tax credit. For your family's needs, $100 may still be too expensive, and you might want to look for either a bronze or you may be eligible if you're younger to get into a catastrophic product, but you may be able to use that money to spread it further. Conversely, if you were actually able to afford in your finances to pay the $200, you might want to look at more comprehensive plans. So as we spoke yesterday, the higher the metal tier, so when you get to platinum or gold, you're getting a broader breadth, more comprehensive amount of coverage. You're also typically dropping attachment points for how much deductible you have to pay or how much cost sharing has to be incurred, or you may be changing what that maximum out of pocket is. So you can use this advanced premium tax credit to actually buy more coverage rather than just using it at the silver. At the same point in time, silver may be what you want. Cost sharing reduction is, again, financial need based, and it's available again only on the exchange, and it helps pay out of pocket deductibles, co-insurance, and co-payments. So if we go to, again, let's go to the next slide. And let's go one more. Great. I think you, oh. So I'm sorry, let's go back one. Thank you, sorry. So insurers that are offering plans on the exchange or marketplace have similar products off the exchange. And this is something to keep in mind. Sometimes the plan might be exactly identical, or they may have another version that has even additional benefit or a slightly different benefit package, and it may or may not be the same price as on the exchange. When you have an exchange product, our insurers are allowed to load some of their risk into their pricing. Off the exchange, they can't do that as much, so the same product might be more affordable off the exchange. And for a family that you're assisting or an individual that you're assisting who may be not eligible for any advanced premium tax credits, or whose premium tax credit is pretty nominal, it may be worth their consideration of looking off exchange. It's a much more difficult process, and this is when you're going to need to hand off to a licensed insurance intermediary or an insurance agent, or have the individual contact the insurer and have them get in touch with an agent. This is not something you're going to assist with. This is not something you're going to advise about, but you do need to be aware that they can find that. Again, if you're looking for coverage because of a loss of a job or loss of your insurance, or had a life event, you do get to have the special enrollment opportunity both on and off the exchange. So let's go to the next slide. So healthcare is probably one of the, not that other lines of insurance don't have a lot of acronyms, but we clearly do have a whole bunch of alphabet soup within our field of health insurance. And when you're selecting a plan, you want to be comfortable with the terminology that you see. A health insurance policy is a legal contract. Insurance companies agree to provide coverage in exchange for you paying premium and your out-of-pocket costs. So when you're looking for that, the types of plans are going to change how they want to finance this. So many of you are familiar in Wisconsin with managed care plans. They also go by the name of defined network plans. And what they have done is incentivize a consumer to use a set of providers who they've negotiated rates with. So it's advantageous financially for them to have their enrollees use those providers, and that they, because of costs that they've negotiated, but that part of that cost is also going to come to the consumer in the form of a lower premium. So you're going to see defined network plans. You're going to also see products called PPOs, which are preferred provider organizations. Those tend to be a little looser, but again, you're going to really need to pay attention to those, where those network lines are. And point of service is probably one of our broader ones, which means you can get care pretty much any point of service location that you go. Those aren't as frequent anymore. More frequently that you're seeing, and especially on the marketplace, when you're seeing plan delineation, so the same insurer with multiple plans, you're going to want to look through that network very carefully, because some of those costs, that cheaper plan may be cheaper because they've significantly restricted the number and type of providers you can use that are in network. And they may have no coverage outside of an actual emergency, no coverage off that network. So when a consumer comes to you and has a very finite group of providers, maybe because of pre-existing conditions that they're already dealing with, or they're anticipating needs of a pediatrician or family history, they want to be sure that a certain specialist is available, they need to look through those networks very carefully, which is why OCI requires insurers to keep their provider network directories up to date, so that you can rely on those representations that Dr. Smith is going to be there. A preferred provider plan is going to have a little more flexibility, but again, you're going to want to be really careful where you get those services, and they may require certain types of services to only be received from preferred providers. Often it's your preventive care that you get, or your routine care. They want you to use that network because they've negotiated for that. Providers have been willing to lower their reimbursement rate because they're going to get a higher volume of patients. Be careful when you go less expensive on these EPOs, or exclusive or skinny kind of plans, because those are going to be extremely restrictive on who you can see for what services. The other thing to remember with these, when you're looking at these networks, is sometimes any one of these, an HMO, a PPO, or EPO, might also use places that are called centers of excellence. So I believe UW-Madison is a center of excellence for transplants. And many insurers have a contract specifically just for transplants. So they want you to not go to your local facility for a transplant, but they want you to use these centers of excellence. And so while it may not be part of your typical network that you use for that service, they want you to go to that center of excellence. You're going to see this. All this information is going to be contained in the policy. A lot of this information is going to be summarized in what's called a summary of benefits and coverage. So let's go to the next slide. So in selecting insurance, one of the first things you need to remember, and when you're talking with people, is all the different components of cost sharing. So when you're looking at what's affordable to yourself or to the consumer who you're helping, you need to not stop at the premium. You need to also include the cost sharing, because they're going to come in coinsurance, copayments, and deductibles with a maximum out of pocket. But all of that is also going to have to be paid before there's going to be coverage from insurance, with the exception of the preventive care services, which you can get without cost sharing. So when you're thinking what's affordable, if I have $200 a month to pay for health insurance, I need to be sure I'm not using all my $200 a month on a premium, because I'm also going to be responsible for paying co-insurance, co-payments, and deductibles. So when you're presenting or providing the screen when 8healthcare.gov pops up a different plan to look at, and you're comparing, it has a really nice compare feature where you can pull up multiple plans and different metal tier products. You're going to want to see, and what you're going to note changing is the amount of this cost sharing. So again, this goes somewhat to your affordability, your budget needs, but also to the coverage and your tolerance of risk. So if you can afford more coverage, you're going to likely pay a higher premium, but may have lower cost sharing. So it may help people who have more fixed regular income to have very predictable monthly expenses versus having really high deductibles and cost sharing, which are all going to be front loaded. So an insurer is not going to be, on the hook to start paying maybe many months into the year. You're going to be paying everything ahead. For some people, they can budget that just fine. That works for them in their family budget, and they can afford to pay, $1,000 deductible, or they can handle the $1,000 deductible plus a 20% coinsurance and $15 to $75 office visit copayments. And depending on their medical needs, they may hit them early or they may hit it late in the year, but they're on the hook for all that money in addition to paying that premium. So when you're helping consumers understand the true cost of what this insurance is, make sure you're looking at all the components and it's cumulative for what they're exposed, so that they understand and they're not surprised when they have now comprehensive coverage, but they still have to make payments right away because they're going to need to meet that deductible or their co-payments or core insurance right away. Until that deductible is met, the insurer is not going to pay, except for, again, designated certain types of services. Next slide. So in this cost sharing, again, this is that balance of how much you can handle out of pocket. So this slide walks you through balancing what you're able to pay, willing to pay, and your tolerance of risk for what you want the insurer to pay. So you may be able to think that you can handle that $1,200 of a deductible over a year, because that doesn't come out to too much a month. But what happens if you have something significant happen in January? Can that consumer pay that full $1,200 right away in 1 month? So when you're talking this through about affordability, you need to be sure you understand when you are going to be on the hook for paying and when the company is going to come in. There is always going to be a maximum out-of-pocket dollar amount identified in that summary of benefits and coverage. And it's going to tell you whether or not co-payments or co-insurance are actually going to accumulate towards that max out-of-pocket. Often they may not. So a co-payment office visit amount might not accumulate towards that max out-of-pocket. So instead of looking of getting to a deductible of 1,000, but a max out-of-pocket of 2,500, it's going to take a lot longer to get to that max out-of-pocket. But you may not have to pay a deductible, but you will be paying co-payments or co-insurance. You need to look through those, that is always going to be laid out in a policy, and you need to understand that. And that's going to be on the screen when you're in healthcare.gov. That's also going to help you understand how you are going to be spending your money in addition to that premium. You'll want to understand whether there's a single deductible for all care or whether there's a separate deductible for prescription drugs that might be accumulating to a separate out-of-pocket maximum. So for the consumer in front of you, again, if they have finite money, you need to be sure that you're helping them understand all the different payments they need to make in order to receive ultimately coverage from their insurance company. And the more they get this upfront, the less surprises they're going to experience and the less frustration they're going to encounter when they understand upfront what those costs can be. Next slide. So I've talked about networks before. And again, the reason networks come into play is the ability of an insurer and the providers to negotiate reimbursement rates. It is to the advantage of a consumer who is using a network-based product to be sure they know that they're using network providers. Again, these exclusive provider organizations are incredibly tight, and there may be no coverage outside of those very specific providers. And the most difficulty that consumers have and that we see in complaints at OCI typically tend to arise when somebody goes to a in-network provider facility like a hospital, but not all the providers inside that hospital are necessarily in that same network. So I would always encourage consumers, especially when you're advising them about being aware of their network, to ask questions and ask all the time. And it's really helpful when you have someone come with you to appointments to confirm, this is my insurance, this is my network, and I want to be sure that you are in my network. The office is constantly working behind the scenes to make sure that those surprises, either through surprise bills or balance bills, are getting taken care of. Obviously, there's been some legislative approaches to try to get some control on that, because that's what makes the news. The surprise that you went to down the hallway to the right for your chemo, and that was in network, but when you went down the same hallway to your left for radiation, those providers were not in network. So how does a consumer know? You need to keep checking your network provider directory. You need to call your insurer and say, I have an appointment coming up. Is this provider going to be covered in my network? It's really important. Next slide. The policy is going to identify those things that are going to be covered. The most comprehensive coverage you have are going to have more things covered. The lower level tiers are going to have less types of things covered, but still your essential health benefits. Again, the prescription drugs might be within the product or maybe standalone attached to the product and may be managed by a third-party administrator, in this case, a pharmacy benefit manager. So there may be two different deductibles, there may be two different maximum benefits. You need to look at what the product is saying is going to happen for your consumer. Next slide. There are always, in any contract, limitations or exclusions. An example of a limitation in the slide is probably one of the more frequent ones, especially when there's networks involved. That if you are pregnant during your last 2 or maybe 3 months of your pregnancy, there is no coverage for your delivery, barring an emergency, if you are out of network. They are telling you that upfront because they have negotiated rates for deliveries. And they want to be sure you're at a in-network facility for that delivery. So they're saying upfront in that policy, we may not cover this delivery. If you decide to see, the Tetons and you happen to be in your last 2 months of pregnancy because you want to get that last baby moon trip in, be careful. Because barring something significant happening to you, which I would never want anyone, that delivery might not be covered. Exclusions are items that are just flat out not going to be covered. Frequently, something might be like cosmetic surgery or bariatric surgery. because those things might have, like bariatric surgery has a high rate of complications that are unrelated, and so they may not want to cover that. However, if you had a complication and you ended up with a different illness and hospitalized, you do still have insurance. But do look at those. People tend to forget to remember what's not going to be covered and make sure that it's not something you anticipate needing. So when you're navigating on the next slide, the selection, and you're talking with your consumer about the total policy, you need to look in combination at the premium, the cost sharing, the network, the coverage, limitations, and exclusions, because all those combined is what's going to drive the best decision for your consumer, for the person you're assisting, and for your family, and will keep it away from getting surprises. You get to affirmatively choose that affordability. By taking time to understand each of those pieces of that policy, you're going to minimize surprises and maximize how you want to spend your healthcare dollars. The next slide is a polling slide. So which of the following should be considered when selecting a health insurance plan? Premium, cost sharing, network and coverage, or all the above? So think that pretty music. Okay, so we have the poll in, and not surprising, you all did an amazing job. Yes, all the above is really important to understand. So Adam, if you can give me control to share my screen for the last, actually put up the last slide first. Thank you. So resources that you need to be thinking about as an assister or a navigator is on the OCI website. We have what has to be included as a checklist for each type of policy, each line of insurance, and they're very helpful for you. We have tons of publications and guidance that's available for consumers. They are written for consumers. They are not highly technical. We have bulletins, which is the positions that the commissioner has taken on certain issues, most recently transgender discrimination. You have the Wisconsin Insurance Report, which gives history of what we're doing. It's a public document saying, how are we doing OCI our job? WisCovered.com is a new venture connected with Wisconsinites to get expert help. It was launched with Governor Evers and OCI, and it puts them in touch with organizations like Covering Wisconsin and the United Way 211. It gives a really nice outreach to get immediate care and can help get coverage, also direct you to Badger Care. Again, for this last website that's listed there, and I'm going to then flip to controlling my screen, navigators for this test need to be looking at on our, oops, here we go. I'm trying, Adam.
As long as Mike has made you the presenter, you should be able to share.
Right, and what I want to do is share my screen, not share my file.
Gotcha.
And there we go. So you should see in front of you now the OCI landing page. And This is where you heard me talk earlier, and we have just a couple minutes. This is where I want you to play and become a good friend with. This is where you're going to find consumer, all of our consumer brochures and information, including mandates, including special topics on opioids, different things on all lines of our insurance. This is where if you typed an intermediary guide and you hit search, you're going to get the results that show this is the intermediary guide for Wisconsin insurance law. When you open it, it is the guide, and we're suggesting that for getting ready for your exam, you're looking at chapters 1 through 4. Also, this is the landing place where you're going to get, so if we go back and do a search on the term Navigator, you're going to land on a page that is set up for licensing navigators and CACs. This page is going to have all the materials. It's going to have the frequently asked questions and responses. And again, this is going to be a really useful tool for you to find information if you have a question about the job that you're going to be performing. So I'm going to leave it at that. Please find your OCI website. Feel free to play around in it. And this is your best place for studying for this exam. Thank you, Adam. Thank you, Eric. Do we have any questions?
We have a couple that came in directly to me. I responded to them, but so one question is, can a person qualify for both advanced premium tax credits and cost sharing? And the answer to that is yes. So if somebody is below 250% of the poverty level, they will qualify for both. And then another question, Julie, I think you started to address this just now, actually, is where is there a good place to find all the terminology and meanings that you went over today? One place is the Marketplace website, healthcare.gov itself. It has a lot of good terms, but I'm assuming some of the publications you just mentioned have some good terminology spots.
Correct. So our website has, in every one of our publications, we're going to have definitions that are used in various terms. You're going to find, so in like the frequently asked questions, or if you look up what is a navigator from our homepage, you're going to find all the vocabulary that we use. There's a consumer guidebook that goes through the basics of health insurance. And it's going to tell you all those terms. It's going to explain them very simply and very straightforward. And it's a great place to look for some of that help. Healthcare.gov also has that same kind of thing. And that's as well as the Centers for Medicare and Medicaid.
Question came in, it may be a little subjective, but your opinion on, are the polling questions that you guys
Adam,
provided?
I didn't hear you.
Okay, sorry. Just it might be a little subjective, but are the polling questions you guys provided similar to the questions on the exam?
Our polling questions today were to really, it's a requirement that we make sure you guys are paying attention and seeing the slides. There is nothing that we're going to do in a test that's going to be so obtuse that if you did some basic work, you're not going to be able to answer. If you paid attention during our presentations and DHSs and you look through these documents, you should be in very good stead for taking the test.
Yeah, I think that's right. I'll give people a second to ask a few more questions. Just a note on one thing that came up earlier. Remember, so as you're thinking about your roles as CACs and navigators, remember, it is not your job to recommend a plan or guide somebody right into a plan, but it is your job to educate somebody and answer all of their questions until they feel comfortable selecting a plan. So, you know, there will be consumers who come right to you and say, hey, which one should I pick? Or will you pick this for me? The answer is no. You're going to want to just tell them, no, I can't, but we can keep looking at this. I can guide you through the summary benefits. We can look at all the what's covered, what's not. And once they feel good that they've gotten the answers that they needed, they will be able to select that plan for themselves. Question just came in regarding mandates. If someone has an insurer with very focused facilities providers and they have an emergency and are taken to an out-of-network facility, is the insurer mandated to cover emergency charges? Which is a great question.
It's a great question. There is a prudent person standard in Wisconsin for coverage of emergency services. So it doesn't have to be a certified emergency. It has to be from a reasonable person who feels that they should go into the emergency room to receive care. And yes, they are required to pay at an in-network level for that provider. So that means you're in network as though even though you're an out-of-network emergency location, your cost sharing is going to be at an in-network level. The potential does exist unless you are in an HMO, that there's a potential that the provider who is a non-network provider could balance bill some of those charges. So if at all possible, whenever possible, get to your facility.
Right, but that is a good standard, is to be for the reasonable person and not necessarily the provider themselves. What chapters, again, for the study guide, 1 through 4? Correct me if I'm wrong, I think that's right.
Correct.
Back to the interactive map, rural customers frequently have to leave their county for primary care. Do customers need select insurers in the county they live or where they receive primary care?
So when you put in your residence, it's going to bring up your geographic area. So your insurance is tied to where you live. If you're getting employer insurance, it can be where the employer is, and you get sometimes that choice. A lot of people in southern Wisconsin may live like in Whitewater, but work in Madison. Some employers allow you to choose one of those 2 locations, but primarily it's where you live. So yes, you may need to travel, but each county is going to have insurance, or each geographic region is going to have insurers that provide coverage in that region, which is why if you move, you might have an SEP because you are no longer in a service area for that provider.
Right, and just a note, one of the most important things when selecting or helping a consumer select coverage is probably for them going to be, hey, can I still see X doctor? Can I see the primary care physician I have now, or I need this specialized service? Can I see this doctor? You'll want to check the benefits, the network that is presented on healthcare.gov. But when in doubt, always call the insurance company directly. They change networks all the time, every year. Specific doctors may be, just by being at this facility, aligned with this plan. And it's a really good idea to get that answer directly from the company for that year, just because I have seen errors on the Marketplace website, and it's just good to double check so the consumer knows they've gotten the best possible service.
And and Adam, just very quickly on that same point, if for some reason you have selected a plan and the insurer, the defined network plan, a managed care plan, has made representation that this primary doc is going to be available, barring that physician leaving the state or the physician being taken out of the network for misconduct, you get a right to continue seeing that provider for that full year. So there are some protections that OCI has in place. So if you hear about it or have concerns, also reach out to OCI.
Great, thank you. A couple more. I just want to make sure I understand. Regarding the APTC, let's say consumer Adam, age 40, has ESRD and is coming up to the end of their COB period and will be eligible for Medicare Part B in 6 months. He would not be eligible for that APTC any longer. I would say to rephrase that a little bit, just so I think, in case people weren't following. So basically, once somebody becomes eligible for Medicare, they're not going to be eligible for APTCs because they're eligible for this other coverage. I think that's the point, most important thing to get across. Would you agree, Julie?
Yes. And the window, though, is what can also often be confusing, because until your enrollment date is going to be a specific date, like with Medicare, then you have that time where there can be some overlap, but you do lose those other benefits. So you do want to be aware of it and plan ahead for it. So if you're advising someone who is going to be turning 65 and become eligible in the year, they may want to consider whether or not they want to take advantage of those advanced premium tax credits or use it rather later as a tax refund.
Awesome. Where can the federal training site be found before taking the CAC exam?
And I believe that's in healthcare.gov.
So yeah, there's actually the CMS portal, so it all kind of lives under the same umbrella, but it's there's a program, module it's called, inside the CMS website called MLMS, which has the training in it, and your organization should be able to help you get access to that if they have the certification they need.
So Adam, I just put that link up on my screen for you. So this is the registration and training.
Yep. That looks right to me. And then, is there a way to get paper study guides in the mail?
Because of COVID, we have very few people actually in the office, but that can be, if you sent a request to OCI Records, you could, I believe we'd be able to print it out for you and mail it.
Very cool.
Again, it's a pretty big document. You're just looking at chapters 1 through 4.
Right. And also, if it's online, you do have the benefit of being able to search for specific terms you have questions on.
It is searchable.
I'm not seeing any other questions. I'm just going to scroll up real quick to make sure I didn't miss any. Oh. Let's see. I think we are all good. Well,
Great.
Thank you, Julie, and thank you, Eric, for coming in and doing this with us. Really great information. I'm really happy with the presentation this year, and I think everybody got a lot out of it. Really great participation from everybody. Good luck with your exams. Looks like I see Allison, so she might want to give a couple closing remarks, and we're going to need everybody give Julie and Eric a round of applause from your home. So, okay. Thanks, guys.
Yes, thank you very much. And just, so yeah, congratulations for getting through this first week. We start up again next Tuesday. Monday is Yom Kippur, so we'll start on Tuesday at 9 a.m. And so you'll get more information if you haven't already with links to that. So please be on the lookout, and great questions, everybody. And we will see you then. Have a great rest of your week and a really good weekend. So thank you.
Thank you.